Assalamu alaikum, Ramadan Kareem. So this is Lara Samhan, and I hope you all are doing great. And I'm really so proud of you guys to have Ramadan and to have your exams after Ramadan or after Eid. And you guys are studying and you doing your best. So mashallah, I'm really so beyond proud of you. And me and my colleague Bushra will all the way carry this physiology review session about reproductive questions. And you guys, please feel free to ask any questions throughout this session. And even if you guys have any questions, either from our session or after the session, you have the freedom to kindly share with us whatever question you have through our WhatsApp numbers. And of course, it's always our pleasure to help. So let's start off with the questions. And before starting off with the question, we would like to have a very quick review on what our scope in this session will basically cover. So since we're going to cover more about the physiology practice questions, like more about reproduction, so we're going to talk more about the male and the female chromosomes, and then just to have a general idea, and then inshallah we're going to start off solving the questions. So basically for the male, as we already know from basic science in school, male chromosome is XY, female chromosome is XX. Males have the testes, organs or the gonad, and the female has the ovaries. So for having a female phenotype, we should have no anti-Mullerian hormone and there is no testosterone. If we don't have both of those hormones, that means this is a normal female phenotype. Compared to the male phenotype, we should have both hormones, the anti-Mullerian hormone and the testosterone, for us to have a normal male gonads and normal male hormones. So in regard to the testosterone, it's basically produced from the Leydig cell. And this is actually a common asked question, even in board exams. The usual, even though it seems to be basic, but actually some people mix it up. So just remember that always testosterone is produced from the Leydig cell in the males, and the anti-Mullerian hormone is produced from the Sertoli cells. Now moving on to the hypothalamus and pituitary axis. As we know, the hypothalamus triggers the pituitary gland to produce whatever hormone. We have many hormones. For our scope in this session, we're going to basically focus on the reproductive hormones. So in regard to the male, I'll talk more about the male related questions in this session, and my colleague will cover more onto the female related questions. So in regard to the hypothalamus pituitary axis, as we said, the hypothalamus will all the way stimulate the pituitary gland for stimulating whatever hormones. In this case, we're going to talk more about the FSH and the LH hormone. So as we said, the Leydig cell is the one that's going to produce the testosterone, and this all the way comes from the LH. So the pituitary or the anterior pituitary gland will produce the LH hormone, and this LH hormone will trigger the Leydig cell to produce the testosterone. Same goes all the way to the Sertoli cell. Basically, the anterior pituitary gland will produce the FSH hormone, and then this FSH will trigger the Sertoli cell to be all the way produced. And of course, we should always have negative feedback, and this negative feedback is quite important for us to maintain a normal homeostasis in the body. So as we can see here, this negative sign is basically a feedback. There is a negative sign in here, negative sign in here. All those feedbacks are quite important to maintain normal physiological function of the body and to prevent any excess or any decrease in whatever hormone or any other metabolic functions in the body. So I'll just cover very briefly the ovarian cycle, and my colleague will talk more about the ovarian cycle. So basically, this is just a summary of the ovarian cycle. So what does the ovarian cycle has? It has two phases. We have the follicular phase and also we have the luteal phase. In the follicular phase, we have a couple of changes that happen compared to the luteal phase. And those two phases are like a complete like ovarian cycle. What exactly happens? So as we can see here, we have those graphs in different colors that actually present different things that happen. For example, starting off with the LH and FSH, we can see in the follicular phase, the FSH is quite increased. An easy way to remember it, because this is also a common asked question, is that just remember FSH starts off with F and follicular phase also starts with F. So F is with F. So in the follicular phase, we have an increase in the FSH more than the LH. Compared to the luteal phase, an easy way to remember it, remember luteal phase is L and LH is also L. So L with L. In luteal phase, we have more of the LH compared to the FSH. So as we said, this is a common asked question, is that in the follicular phase, we have more of the FSH. Compared to the luteal phase, we have more of the LH. And as we can see here, we have also different or changes in the body temperature. The progesterone is more on the luteal phase, and this actually increase in the progesterone is quite important to know if there is, for example, fertilization and implantation of the embryo that will happen, or there's no need. If there's no need, the uterus will all the way shed to the shed, and the menstrual cycle will all the way go. So basically, this is just a very quick overview of the ovarian cycle, and inshallah, my friend will cover it more in her questions. So starting off with our very first question, you guys have the freedom to kindly read the question and answer it, and then inshallah, we can discuss the answer all together. So this is the first question, and what do you guys think is the answer? Perfect. Exactly. Excellent. Yes, salam alaikum. Excellent. So as we said, the leading cell is the one that produces the testosterone hormone. صح? So the correct answer is number three. And as we said, this question is actually asked in board exams. Okay, so the correct answer, as you guys said, mashallah, is number three. Perfect. Let's move on to the next question. Okay, any other ideas? Okay. طيب, the question says the purpose of the prostate gland. So the prostate gland is a gland. Any gland basically secretes, right? So any gland can have multiple of functions. Okay. So in regard to the prostate gland, it has the correct answer, just to know, is actually number three, to secrete dihydrotestosterone. How this thing happen? Basically, the testosterone is produced from a conversion of testosterone to dihydrotestosterone by an enzyme called 5-alpha reductase. So 5-alpha reductase converts testosterone to its active form that will actually help in the normal physiological function of the prostate gland, which produces basically the dihydrotestosterone. And this dihydrotestosterone helps in the normal physiological function of the male gonads. Okay, so the correct answer is the purpose of the prostate gland is basically to have this active biological hormone, which is the dihydrotestosterone. Okay, clear? Exactly, perfect. Also, the prostate gland helps in many things, not only just conversion of testosterone to dihydrotestosterone. It also helps, for example, in supplying the nutrition for the sperm, also some of the like nutrition enzymes and like many other things. Okay, so it doesn't only have one function; it has multiple of functions. But for the sake of this question, so like the main function of the prostate gland is basically the production of the active form of the dihydro, which is dihydrotestosterone. Okay, so basically this slide just says what does the some of the things that actually the prostate gland does. And as we said, we have in here the 5-alpha reductase enzyme, which helps the conversion of the testosterone to the DHT, which is the dihydrotestosterone. It also helps in having some of the prostatic fluid, as we said, that helps in the sperm for it to live longer, and like a nutrition for the sperm. Okay, so as we can see in this picture, just to get oriented, we have in here, this is the urinary bladder, and this is the urethra. So both sides of the urethra basically has the prostate encircling it. So what happens is that the prostate basically has some of the openings all the way in here, which have the fluid, which have the prostatic fluid, the nutrition to be all the way ejaculated with the sperm for it to be living longer. Okay, perfect. So moving on to the next question. What do you guys think is the answer? By guess. Okay. It actually lives longer. So the lifespan of the sperm in the woman's reproductive tract, as we know, the woman's reproductive tract is quite acidic. So this acidic environment doesn't really allow the sperm to be living too long, like for weeks or months. This is why many sperms actually die even from the once it's been ejaculated. Even despite some of them actually live for a quite long period, and this period that they can live maximum is approximately 1 to 2 days. So the correct answer is number two. Okay. So as we said, it can't live longer because of the acidic environment of the uterus and many other factors that basically kills many of the sperms. And of course, the strongest sperm, if basically you have the strongest sperm, is the one that will all the way go for fertilization and succeed in the fertilization. Okay, perfect. Moving on to the next question. What do you guys think is the answer? Any guesses by chance?
I don't understand the question.
Okay, perfect. We're gonna explain, don't worry. Right, so the question says a man is taking a medication that interferes with the emission phase of the sexual act. Which of the following would solve this problem? So as we know, during the intercourse or during the sexual act, we want the male gonads to have vasodilation and to be relaxed. And this can basically be aided by the parasympathetic system. It helps in the vasodilation of the vessels, it helps in the relaxation of the muscles, and this will help all the way in the ejaculation and to have a correct sexual act or a correct intercourse. So if we had any medication that interrupts this thing, for example, a medication that is, some people basically take medication that simulates the sympathetic system. And if this sympathetic system is being stimulated, that means we're going to have no relaxation of the muscle, no relaxation of the vessels, right? So we're going to have vasoconstriction. And this vasoconstriction doesn't really allow a correct like intercourse to be happening and maybe can actually like prevent for example, sperm ejaculation, etc. So basically the idea of this question is that it just says that some, like for example, men take medications that are more that basically stimulate the sympathetic system. And as we said, if we have more of the sympathetic system, that means we will have decrease of the ejaculation, decrease of the muscle relaxation, decrease of the vasodilation of the vessels, and all of those factors prevent a correct sexual act, right? Which may lead to, for example, decrease in the ejaculation of the sperm, etc. So, so basically, how to prevent this thing from happening is that to give a sympathetic nervous system blocker. In other words, to give a medication that leads more to the parasympathetic action, which actually helps in the vasodilation, which helps in the muscle relaxation, and that lead to a correct sexual act. Is it clear?
Yeah, that's great. Thank you.
Perfect. So the correct answer is number one, which is a sympathetic nervous system blocker. Okay. So we should give this guy a sympathetic nervous system blocker, like a medication that has this thing, so that we don't want the sympathetic nervous system to play a big role, and we want the parasympathetic to actually act in having, as we said, vasodilation, muscle relaxation, to have a correct sexual act, and to have a proper sperm ejaculation. Okay. So moving into the next question. What do you guys think is the answer? Exactly. You guys are correct. Exactly. Acrosome. So basically, the question says the anatomical structure of the spermatozoon that's important in producing the enzyme that hydrolyzes the zona pellucida. As you know, the zona pellucida is basically the thing that uncovers or encircles the oocyte. Okay. So basically the sperm or the spermatozoon, the most important thing for it to all the way penetrate the oocyte for fertilization is to actually break the zona pellucidal layer. And how this thing happens is basically by the enzyme that the sperm head has, which is the acrosome. So as we can see here in this picture, this is basically the sperm. We have here, this is basically the tail or the filament. We have here the mitochondria, the centriole. Let's focus on the head. This head, as we know, it has the genetic material, which is inside the nucleus, and it has on top of it, it's like basically a cap, which is called the acrosome. So this acrosome is an enzyme that helps in hydrolyzing the zona pellucida layer, as we can see in this picture. This is, let's say, the egg or the oocyte, and we can see here many sperms that try to penetrate, and the sperm that has factors, for example, like acrosome layer that hydrolyzes the zona pellucida faster, the stronger sperm, and like all factors is the one that will succeed all the way to be the first to penetrate the oocyte or the egg and help or aid in the fertilization. So you guys, mashallah, answered correctly. Perfect. So moving on to the next question. Yeah, Salah, excellent, exactly. We discussed this question, mumtaz. So it says, what system controls penile erection in the male? As we said, it's very important to have relaxation of everything, relaxation of the muscle, relaxation of the blood vessels, to have a correct ejaculation and ejection. So the correct answer is the parasympathetic nervous system. Perfect, mashallah. You guys understood, alhamdulillah. Okay, so moving on to the next question. So this question has a couple of sub-questions under it. You just understand the general idea of the question, and inshallah, we're going to discuss it together. Okay, so let's read the question. Okay, so this question says a 51-year-old male presented to the physician with a complaint of difficulty maintaining an erection during sexual intercourse. And by the way, this complaint in the urology clinics is very common. Like we always hear it, especially with older aged males. Okay, so during a history and physical exam, he said he has been a diabetic since he was 8 years old. He had some problems with retinopathy. Retinopathy is basically a problem in the eye, to be more specific, in the retina of the eye. So once you see a patient who's diabetic, as you know, diabetes is going to affect the whole body. So this sugar particles or the glucose particles can affect anywhere in the body. Most commonly, it can affect the eye, causing retinopathy. It can affect the blood vessels, causing coagulopathy. And as we know, if the blood vessels are going to be affected, of course, the benign blood vessels will also be affected, which will have difficulty in the sexual intercourse. Because of that, like it makes sense. This patient has diabetes, he has retinopathy, he has difficulty maintaining the erection, because as we know, since those, for example, glucose particles will, let's say, be deposited in the penile blood vessels, it will, the parasympathetic won't really be working like properly. There is no enough relaxation, for example, of the blood vessels, so this will lead to difficulty in the erection of the canal. Okay, so this like whole scenario makes sense. Like you understand the holistic thing, why this thing actually happens. Tamam. And then, as we said, he has urotenopathy previously, and he's now taking those medications. So the first question or the first question says, is it likely that this individual is suffering from which of the following? What do you guys think? As the scenario said already, he's suffering from what? Ya salam, mashallah, exactly, suffering from erectile dysfunction. And as we know, it already made sense because he's taking medications for his diabetes and for other stuff. Plus, he has diabetes. So all those things aid in not having a correct or a proper erectile, which cause erectile dysfunction. Tamam? Okay, so we answered, mashallah, the first question correctly. Moving on to the second sub-question. What do you guys think is the possible cause for this presentation? So as we said, he's basically having diabetes and he's taking medications. So what do you think is the cause? Okay, perfect. Exactly, the medications. As we know, some of the medications basically are, for example, sympathetic medication, right? So if we have sympathetic medication, that means the parasympathetic won't really work very efficient. So if the parasympathetic isn't working effectively, we won't have relaxation of the muscles, we won't have relaxation of the vessels, right? And it's really always very important to focus on the medication history, because at the end, trust my words, many doctors just keep taking history, doing physical exam, labs, many things, and they don't really know like what's the cause of the presentation of the patient. And sometimes they tend to forget to ask about the medication history. And most of the times, it's basically a medication side effect that caused this whole thing. So from the beginning, if you just moved with the Socrates and you just ask the once it comes to medical history and the medication history, if you asked about the medication, خلاص, you can definitely just know the diagnosis and just do a proper treatment. So because of that, it's really very important always to put in your mind the medication history. Exactly. So we have a question in here. Okay, so exactly, angiotensin is going to cause vasoconstriction, but our patient is taking ACE inhibitor, which is the angiotensin converting enzyme inhibitor. So angiotensin is going to cause vasoconstriction, but ACE inhibitor will cause vasodilation. But even though he's taking ACE inhibitor drugs, whatever ACE inhibitor drug, other drugs, for example, that he's taking might actually cause this vasoconstriction or cause the sympathetic nervous system to be stimulated. Plus, as we said, he's having diabetes. This can actually be one of the like causes that can cause the like difficulty in the erection. Okay, even though he's taking ACE inhibitor, which causes vasodilation. Clear? Okay, perfect. Okay, moving on to the next question. So it's the third sub-question of our question. So what treatment would you recommend for this individual? So guys, احنا we want a treatment. Yes, سلام عليكم. Excellent. We want a treatment that does vasodilation. صح ولا لا؟ صح. So which of the following causes vasodilation? Of course, it's the PDE5 inhibitor, which is the phosphodiesterase inhibitor. Now, what does this phosphodiesterase inhibitor does? As we know, if we basically give any medication that has the phosphodiesterase inhibitor, for example, like sildenafil, vardenafil, tadalafil, all those like medications of the PDE5 inhibitor, it does for us the vasodilation. So we can see in this diagram a vessel, which is here a dilated vessel. If we gave PDE5, it constricts. But if we gave PDE5 inhibitor, like any of those drugs, sildenafil or any of them, it will all the way cause vasodilation. And as we said, this helps in the parasympathetic, it helps in the visualization of the vessels, it helps in the relaxation of the muscles, which will aid in the erectile without any dysfunction. Okay, so this is in the PDE, and usually PDE5 inhibitors are commonly given in any of the patient who has erectile dysfunction, and also helps in the pulmonary hypertension by vasodilating the vessels, and it causes the smooth muscle relaxation of the muscles. Okay, perfect. Now moving to the new question. What do you guys think is the answer? Okay, perfect, exactly. The answer is number 3. So this question says the mechanism by which the zona pellucida becomes hardened. Once you see the word hardened, that means, and most of the times, maybe calcium has been involved. As we know, calcium, generally speaking, makes anything hard, so on the bone, so on the teeth, even in the physiological functional antibody. Once you see anything that's hardened, even inside the body, if anything is hardened, that means most probably there is a calcium deposition in there. So, you know, like if you really understand the concept that calcium, once it's being deposited anywhere, it hardens the thing, it applies everywhere, anywhere. So once you see the word hardened, plus if you know that calcium hardens whatever, you will know that the answer is immediately something related to the calcium. So it says in here, the mechanism by which the zona pellucida becomes hardened following the penetration of the sperm. As we know, once one sperm succeed in penetrating the egg or the ovum, that means we don't want any other sperm to all the way penetrate. خلاص, this sperm want to be the most unique sperm. It enters. It doesn't want. It's quite selfish that it doesn't want any other sperm to enter. So we have the situation of the calcium that hardens this zona pellucida layer and doesn't want any other sperm to all the way enter, or at least have difficulty for other sperms to be entering. So the correct answer is that we have an increase in the calcium in the oocyte. Okay, so as we can see in here, this is the oocyte and this is the sperm. Once one sperm begins to enter, the genetic material of the sperm enters, immediately we have the calcium that's going to all the way, the intracellular calcium is going to all the way be going outside to this layer so that it hardens it and prevent any other sperm to be all the way penetrating the oocyte. Okay, perfect. Moving on to the next question. What do you guys think is the answer? Okay, perfect. Very good, excellent. So, in the hypothalamic pituitary gonadal axis of the female, which is the follicular, which is the follicular cell that will basically produce inhibin. So, as we said, we always have positive feedback and negative feedback, and this negative feedback is always important so that we try as much as possible to maintain normal homeostatic physiological functions of the body. So for the thing that actually does this follicular cell type is the granulosa, and I got you here a picture. So as you can see here in this image, so this is basically the oocyte, as we can see in here, this is the oocyte. We have around the oocyte the zona pellucida layer, and we have in here the granulosa layer. As we can see, this whole thing is basically the granulosa layer, okay? So this is just a section of the granulosa layer, the zona pellucida, the follicular cells, the thecan cells, okay? Okay, perfect. Moving on to the next question. Okay, what do you guys think is the answer? Perfect, excellent, excellent, exactly. So what hormone initiates the spermatogenesis? It's basically the FSH hormone. Now, what is spermatogenesis? So basically, Genesis is basically like a path that has something moving from one thing to another thing, from one thing to another thing. So as we can see here in the left side, for the spermatogenesis, it's first to start off with the spermatogonium, like the baby spermatogonium. And then after that, it starts to mature till it becomes this final looking sperm, which has everything, the acrosome, the nucleus, which is the genetic material. And as we know, during fertilization, not the whole sperm penetrates the ovum, it's only the genetic material, the material that's basically injected all the way into the ovum. So here we have this is the nucleus, we have the mitochondria for the power of the sperm to move and everything, and then we have at the end is the flagella for aiding in the movement of the sperm. So for the spermatogenesis, this starts off with a very baby structure, which is the spermatogonium. After that, we have the primary spermatocyte. Once we have primary, we should always have secondary. So this spermatocyte, the primary spermatocyte will become secondary spermatocyte in meiosis 1. And then in meiosis 2, this secondary spermatocyte will be further split into different spermatoids, which is basically around spermatoid, 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 and then we end all the way with the spermatozoa. So we can say that one spermatogonium ends up with the result of having 4 spermatozoa, 1, 2, 3, and 4. Okay, this is why once the ejaculation happens, we have millions of sperms that are actually all the way ejaculated, because from one spermatogonium, the baby one, it produces 4. So imagine if you have hundreds, thousands, and millions of those spermatogonium, like we're gonna have basically endless numbers of the mature sperm or the spermatozoa. Okay, so moving on to the next question. Okay, what do you guys think of the answer? Excellent, that's what I'm going to exactly. So during the follicular phase, the dominant follicle arises in response to which of the following? So as we said, in the ovarian cycle, we have the follicular phase and the luteal phase. So as we said, follicular phase is basically F, and the most hormone that will be actually rising higher is the FSH compared to the LH. So the correct answer is FSH. So as we can see here, this is another diagram of the ovarian cycle. We have in here the follicular phase, here we have the luteal phase, and here in day number 14, we have the ovulation. In the ovulation, the highest hormone is going to basically be the LH hormone. And in the follicular phase, as we can see here, the FSH, which is blue in color, is quite higher than the LH, which is pink in color. And the LH is going to be sky high during the ovulation phase or during the day number 14. And moving on to the luteal phase, where basically we have, as you can see here in the uterus, we can see here this reddish thing is basically the endometrium. It keeps thickening, 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 and this thickening happens basically by the progesterone hormone, which is purple in color. Progesterone hormone goes very high during the luteal phase, so that hoping for fertilization and implantation to happen successfully. In case there is no fertilization, no implantation, all of those endometrium, the thickened endometrium will all the way shed into the menstrual cycle, and then again this whole ovarian cycle starts all over. Yeah, so perfect. Moving on to the next question. What do you guys think is the answer? Any guesses? Okay. Right. The question says the acrosome of a sperm is formed by what? The acrosome, as we said, is the very first layer of the sperm. So the correct answer is number 2, which is the Golgi complex of the sperm head. How this thing happened, as we can see here, this is basically this blue thing is the end of the sperm or the head of the sperm. So we can see this blue thing is the head of the sperm, and this yellowish thing is the acrosome, which is the layer on top all the way of the head of the sperm. So we can see here this is the sperm, the blue thing is the head of the sperm, and this reddish thing, which is here yellow, is basically the acrosome. So in the acrosome, the most important thing is the Golgi phase or the Golgi apparatus. Okay, clear? Okay, perfect. Okay, moving on to the next question. So the question says, excellent. So the question says the actual genetic section of the sperm, as we said, once the sperm succeeds in fertilizing the egg or the oocyte, the only thing that enters is the genetic material. The whole sperm as a whole doesn't really enter. Okay, So the head of the sperm is the one that's responsible for the genetic material. Why is it the head? Because it actually has the nucleus. As you can see here, the sperm, this is the head, and this is the tail of the sperm. We have mitochondria. So the genetic material, which is the DNA and everything, is basically available in the nucleus, which is inside the head. This is why we basically have the genetic material is the only thing that will all the way aid in the fertilization with the oocyte, and then just we have the whole embryo thing. Okay, perfect. So moving into the next question. Okay, any guesses? Okay, perfect. So the question says the correct sequence of cell stage in spermatogenesis. So basically, this is like a pure memorization. The correct answer is actually number 4, which is it starts off with spermatogonia, spermatocyte, spermatids, and lastly the spermatozoa. I have here like a picture of it. So in regard to the spermatogenesis, as you said, any word that ends with genesis is basically like a process that moves from one phase to another phase. So in this thing, as you can see in here, this is, for example, site of the spermatogonia, as you can see in here. Then the spermatogonia goes all the way to become a spermatocyte, sperm 1 and 2. And then this spermatocyte becomes spermatid, as you can see here. And lastly, we will have the mature sperm or the spermatozoon. So the spermatozoon is the very most mature sperm. Okay? Okay? Perfect. So those are my questions for today. And I hope you guys enjoyed and learned. And of course, I'm more than happy to have any of your questions. If you guys either individual or any other questions in general, I'm more than happy to help anytime you guys would like. We can even open Zoom anytime you guys would prefer. And I'm always more than happy to help. So I'm always more than proud of you. I know it's quite difficult to have Ramadan and studying at the same time, but inshallah, يعني, everything will pass way better bismillah, and may Allah reward you on like the double efforts you guys put, and inshallah everything will pay off, inshallah, my future doctors. So that's it for today, inshallah, and I hope you all the best of luck. And my friend Bushra will carry on. Thank you so much. Have a nice day.
Thank you, Lara. Is it okay if we take a couple minute break and then we can come back and continue?
Sure. Thank you.
Okay, Assalamu alaikum everyone. I'm Bushra Rasheed. I'm a 5th-year medical student, and I'm going to be taking over for the rest of the lectures for reproductive physiology, inshallah. I've linked my email address here, and I've linked my phone number as well, so that you guys can send me questions anytime. I'm open to, again, if you need help with anything at all, please let me know, and I would be very happy to help. This is the table of contents. These are the lectures that I will be going over. So endocrine and ovarian cycle, the menstrual cycle, the hormones in pregnancy, and the hormones for parturition and lactation, inshallah. All right, so let's move on to the first question. In the hypothalamic pituitary gonadal axis for the female, what is the follicular cell type that produces inhibin? Is it a cytotrophoblast, syncytiotrophoblasts, granulosa cells, or thecal cells? See, okay, let's look at the answer. Yes, you are right. It is the granulosa cell. This is more than an application type of question. This is a simple recall question. So as you see, I've inserted a picture from Dr. Abdul Jabbar Rasool's lecture. As you can see here, inhibin is produced by the granulosa cells. It just mentions here. But yeah, inhibin is released by these granulosa cells of mature follicles, and it is basically regulated by FSH, and LH. So you need to be able to differentiate between inhibin A and inhibin B, because the doctor can ask, honestly. Inhibin B is a marker for corpus luteum function, and inhibin B is a marker for granulosa cell function. So to know how well the granulosa cells are working, or whether to know, if there's a problem with the granulosa cell, is that why a patient is unable to conceive, you can look at the levels for inhibin B, and that would tell you if the cells are functioning okay. All right. On day 21 of the female reproductive cycle, how do the following hormones change? For this question, just forget that it says estradiol. Let's assume that this is estrogen. So how do you think these hormones would change on day 21 specifically? C. You are right. So day 21, let's look at the menstrual cycle. All right, I'm gonna give you guys a quick overview of this entire graph. So let's start off by looking at the gonadotropin levels. FSH stays pretty much consistent throughout the beginning of the cycle. This is because, again, it's not really going up or down. It's not really oscillating. It's staying consistent because it's stimulating the follicles. It dips down a little bit towards the end when the follicles are mature pretty much. And we know about the LH surge that occurs just before ovulation, and this is what causes the ovulation to occur. Looking at the ovarian hormone levels, estrogen would gradually increase. Why is that? Because when the follicle is maturing, it's releasing more and more estrogen. And yeah, that is why you would see a rapid increase all the way up until ovulation. And then once ovulation occurs, the levels would kind of taper off. Whereas progesterone stays, this is the black line progesterone stays pretty much low the entire first half of the cycle, and that is because there isn't really anything that's sort of releasing progesterone. But then as ovulation occurs, and now you have the corpus luteum formation, we know that the corpus luteum produces progesterone, and so the levels would rapidly increase in the luteal phase of the cycle. This, if we were to look at day 21, you can see here that the what did the question ask? Oh yeah. So at day 21 specifically, we know that the estrogen is going down because there's no follicles, there's no mature follicles that are releasing estrogen. And the progesterone is actually really high here because of the corpus luteum. And FSH and LH are low at this point because, yeah, low, because you don't really need to be stimulating follicles. You already have the end product of the mature follicles, which is the egg. We're more so focusing on the uterus at this point. Okay, next question. An 80-year-old woman sustains a broken hip after a minor fall from a chair. The only medication she takes are multivitamins. Which of the following is the most likely hormonal profile for this woman? So what are they hinting towards? The fact that it's an 80-year-old woman means that she is most likely postmenopausal, right? So they want us to know the hormone profile in postmenopause. What do you guys think is the answer? Okay, let me tell you guys. So the answer is C. Now, why is that? Is because, how does menopause commence or start? Menopause occurs when the ovarian reserve in the female is completely gone. Right, so ovarian reserve is basically the amount of follicles that you have left in the ovaries. The amount of follicles are they're gone. They're completely gone in a postmenopausal woman. So when you don't have follicles, what do you think is releasing the estrogen? There's nothing releasing estrogen. And so the estrogen and progesterone levels are super low. Now the hypothalamus senses the low levels of estrogen and progesterone, and it releases more GnRH, more gonadotropin releasing hormone. What that does is increases the level of FSH and LH that is released from the anterior pituitary gland, and inhibin goes low because when inhibin goes low, FSH would increase. We know that the relationship between inhibin and FSH are opposites. Yes, exactly. FSH and LH would be high because of no negative feedback. There we go. So the answer is C. What is the consequence of the lack of adequate chorionic gonadotropin after fertilization? So once fertilization were to occur, if we did not have enough HCG levels, which of the following options do you think would happen? A. You're right. So spontaneous abortion. Let's look at why that is. So the HCG is basically the first hormone that is released by the syncytiotrophoblasts. Okay. Now, what does HCG do? HCG is a very important integral hormone. It's going to stop the corpus luteum from degrading. When the corpus, or in a way, it prevents luteolysis, lysis of the corpus luteum. Why do we not want the corpus luteum to degrade? Because the corpus luteum is going to secrete progesterone. And what this progesterone is going to do is going to keep the lining of the uterus intact. Because imagine if you were to have, for example, you had a zygote, right? And the lining of the endometrium ended up shedding because there wasn't any progesterone, because there wasn't the corpus luteum. What would happen? The zygote would not be able to implant, or even if it did already implant, if the lining shed, the zygote would end up getting shed in with the menstrual blood, right? So HCG is very important in preventing that. So yeah, that is why abortion wouldn't occur. A 35-year-old woman is admitted to the labor and delivery suite at 4:30 a.m. Her amniotic membranes rupture approximately 6 hours earlier, but her contractions have decreased from 1 in 3 minutes to 1 every 5 to 7 minutes. She is primipara. Primipara means that this is her first child. So again, we're looking here at the question stem, the clinical vignette, and it's super long. Usually the advice that I give in these sessions is that you always go to the last sentence of the entire clinical vignette. Okay, you wouldn't have to waste so much energy, because if you were here, you're looking at the blood pressure. Okay, 140/85. Okay, this is high. Then you look at the pulse, 100. That's okay. Sinus tachycardia. Ooh, okay. Her temperature is really high, so she might be having a fever. You have all of these thoughts when you're going through the question. You have so many thoughts as to what might be occurring. If you were to read the end of the question, let's do it together. If the physician wants to increase the rate and strength of the contractions, which of the following would he give the woman? Now you realize that all of the information that's given here was not even really relevant. But you just really need to read the end of the question. Again, I'm not saying that you're not supposed to read the entire question. Of course, that's not what I mean. I just want to say that when you're doing very, very long clinical vignettes, read the last line first. And now what you can do is go back and look at what is relevant. Okay, just go over it briefly. If you think that there's anything relevant, great. If not, you can move on. You wouldn't have wasted so much energy. In this case, we didn't really need the vignette, right? So what do you think is the answer to this? What would you give the patient to increase her contraction? A, oxytocin, absolutely. Let's quickly go over why. So we have the placenta towards the end of the pregnancy. What the placenta is going to do is going to be secreting a lot of estrogen, right? Something that we know about estrogen is that it increases the receptors on the uterus. So what it's going to do is going to upregulate, or it's going to increase the amount of oxytocin receptors that are produced and that are in the uterus. Yeah. What happens synonymously also is that the hypothalamus is telling the posterior pituitary to release oxytocin. Now this oxytocin goes and binds with the oxytocin receptors, and this causes uterine contractions, right? The more contractions occur, and the more the baby's head sort of goes down the cervix a little bit, that stretches the cervix. And then this is a positive feedback loop where the neuroendocrine reflex is going to go back to the hypothalamus. We're going to be releasing even more oxytocin, even more stretch of the cervix, and that is just how it sort of goes. Yeah, oxytocin. All right, the hormone that is responsible for milk production is... What do you guys think is the important hormone here? B, prolactin. Yes, perfect. Let me just quickly go over this image right here. So we have our hypothalamus, right? The magnocellular neurons they're going to stimulate the pars nervosa to release more oxytocin. Now the function of oxytocin is what? Hold on. Sorry, I'll just go over this part first and then we move on to the galactopoiesis. So the function of oxytocin is to increase the concentration No, basically stimulate the myoepithelial cells. Now, as the name suggests, myoepithelial cells. So they're kind of epithelial cells, but they have a muscle component, right? So they are contractile. These cells are present around the ducts of the mammary glands. And so when these myoepithelial cells contract, they cause release of milk, and that is what milk letdown is basically called. What we also have in the hypothalamus is a decrease in the dopamine amount. So when the amount of dopamine decreases, that in turn would increase the prolactin releasing factor, which stimulates the lactotropes to produce more prolactin. And we know that prolactin, again, is the hormone that is responsible for galactopoiesis. Poiesis means synthesis. Galacto would mean milk, so the synthesis of milk. And so with the help of prolactin and oxytocin, milk letdown occurs. And one other thing that's really important here is how does milk letdown occur, like what the stimulus is. Suckling at the nipple, so when the baby first latches on to the nipple. Also hearing babies cry, when the mother hears the baby cry, immediately that will just cause milk letdown for the baby. And yeah, I think lactational amenorrhea is also an important topic, so let me just quickly touch over that as well. When you have high levels of prolactin, it goes to the hypothalamus and it inhibits GnRH, right? So gonadotropin releasing hormone is inhibited. When this is really low, FSH and LH is really, really low. And so you have a phenomenon known as lactational amenorrhea. What that basically is when a mother is lactating, she basically does not get her period. She has amenorrhea because there's no FSH, no LH. It will not increase, it will not cause the production of estrogen, progesterone. The uterine lining is just, there is no lining right now. And so the mother has amenorrhea. And what this basically helps with is that you're not going to conceive when you are lactating. This isn't really proper concept like contraception. There are still chances of conceiving. So if a mother was to get proper contraception, that would be advised versus this. But this is just like nature's method, basically nature's way of making sure that you don't get pregnant again when you have a newborn baby. Okay, which of the following hormones is responsible for milk being expressed into the mammary ducts? We already sort of went over this. That's oxytocin, which stimulates the myoepithelial cells. Okay. The mechanism by which the zona pellucida becomes hardened following penetration of a sperm cell is C. An increase in the intracellular calcium in the oocyte. Yes, you're right. So what happens, let's just briefly go over this diagram. When the acrosome reaction occurs, when the acrosome is, it's released, the hydrolytic enzymes are released, the zona pellucida is digested here, the sperm is able to penetrate the egg. What happens when fusion occurs is that the sperm also releases something known as PLC, which is phospholipase C. Now, phospholipase C, as you see in this picture, is going to cause the cleavage of PIP2 into DAG and IP3. What IP3 is very known for or very characteristic for doing is that it goes to the endoplasmic reticulum and causes release of calcium. Usually, whenever there's calcium release, you will see that it's correlated with some sort of like exocytosis. I'm sure you guys are gonna take this later on as well in neurology specifically. But exocytosis of cortical granules occur. So these granules are just gonna, get exocytosed, they're gonna get transported outside the cell. And then the hydrolytic enzymes that are within the cortical granules are going to react with the zona proteins, and they're going to cause hardening of the zona pellucida, and this prevents polyspermy. This makes sure that no other sperm is able to fuse with the egg. All right. The ovarian reserve is a collective term for okay, someone is saying A, somebody is saying B. Okay, and this is basically the primordial follicles. If you've read textbooks, you don't need to read textbook, but I'm just saying, like, usually the way that ovarian reserve is mentioned is that a baby is born, like a female, like a girl, is born with her ovarian reserve. That is usually the term that they describe, which means that it should be the primordial follicles, because the primordial follicles are what the fetus would even have. The female fetus in the womb would actually have primordial follicles. This is what she is born with. The ovarian reserve is what she's born with. And this is the answer is B for this. Why the answer isn't A is because this says pre-ovulatory follicles. Now, pre-ovulatory follicles could be secondary follicles, they could be tertiary follicles. We are just talking about the primary follicles here, so pre-ovulatory would not be the right term to use. Primordial would be a better term. So someone is saying, isn't the ovarian reserve only the ones that are present by the time menarche sets in? I am not 100% sure. I was under the impression that a fetus is like that a girl is born with her ovarian reserve. She has all the primordial follicles. Is it okay if I get back to you at the end of the lecture? Let me just do some research on this and I can answer your question better, inshallah. We can move on in the meantime. So a key factor in the selection of a dominant follicle is high expression of which of the following receptors? A, FSH receptor. Perfect. So if you look at the question, what they're asking for is what is the most important factor for determining which follicle becomes the dominant follicle? High expression of which receptors? This makes the most sense, FSH receptors. Why? Because if a follicle has a lot of if a follicle has a lot of FSH receptors, what's going to happen is that FSH is going to be able to exert more effect on that. More stimulation occurs, more maturation of that follicle will occur, and this will lead to it becoming the dominant or the Graafian follicle. Okay. A 27-year-old female patient has problems with conception. An abdominal ultrasound scan shows absolutely no structural abnormalities, so a functional sex hormone test is ordered. For that, the biological cycle of the woman is hormonally shut down for a week. So what they're talking about is that her menstrual cycle was completely shut down. And usually the way that that works is that you inhibit the GnRH. When you don't have any GnRH, you don't have any LH and FSH, you don't have any estrogen, progesterone, and so your menstrual cycle is halted for that time. When synthetic analogs of FSH and LH are administered, changes in the estradiol and progesterone are measured. When GnRH is administered, then changes of these are monitored. Which of the following results support the working diagnosis of a problem at the hypothalamus as the cause of the infertility? Now, this is a little bit of a tricky question, but we'll go over it together. So what they're doing is that they're administering FSH and LH, and then they're looking at estrogen and progesterone. Why are they doing this? They're basically testing each level of the hypothalamus pituitary gonadal axis, right? So this axis has three main components. It has the hypothalamus, right? It has the pituitary, and then it has your gonads, or in this case, you would have the ovaries, right? When you're administering FSH and LH and you're measuring the levels of estradiol and progesterone, you are testing the ovaries, right? Because you want to see, we are stimulating the ovary. Is the ovary doing what it's supposed to be doing, as in producing estrogen and progesterone? So this is where testing one part of the axis. When GnRH is administered, changes in FSH and LH are monitored. So now we're doing the second part of the axis, right? We're testing the pituitary, because we're saying we're gonna give GnRH, like we're gonna administer this, and then we're gonna see how well the pituitary is able to react to these. So yeah, when you look at how the pituitary reacts, that will tell you whether the pituitary is working or not, and so we can better look at what the reason for her failure of conception actually is. So which of these, now we're going to look at the table, which of these do you think would indicate that hypothalamus is at fault? So again, let me just go over it briefly again. FSH and LH is administered, and you're looking at the changes in estrogen and progesterone. And then GnRH is administered, and you're looking at the FSH and LH. That is correct. You're smart. Look at you. Okay. So when FSH is administered and estrogen and progesterone increase, that means that, what were we testing with this exactly? We were testing the ovaries, right? The ovaries are completely fine. That is why when you administer these, estrogen and progesterone would increase. Next, the second thing that we're looking at is when you administer GnRH, you're seeing FSH and LH, and with this, we're testing the pituitary gland. If there is an increase in the amount of FSH and LH that is produced by the pituitary gland, what we're basically testing is that the pituitary gland itself is perfectly fine. So now we know that the pituitary gland is perfectly fine because there was an increase in FSH and LH. We know that the ovaries are completely fine because there was an increase in estrogen and progesterone. So the problem naturally has to be in the hypothalamus. And so, like the question said, this is going to be a problem at the hypothalamus as the cause of the patient's infertility. So maybe there is a problem with the GnRH, like pulsatile secretions or something. Okay, next question. The blood level of luteinizing hormone is measured daily in a 23-year-old healthy woman over a 28 days menstrual cycle. So this is just your, normal menstrual cycle. At times A, day 1 is the first day of menstrual bleeding. So this is the first day of menses. At times A and B, the blood levels of various hormones are measured. Which of the following hormones is expected to have the highest B:A ratio? So let's talk about a little bit of maths here. When we're talking about ratios, right, ratio would mean B over A, right? B over A, that is equal to the concentration ratio. For the ratio to be high, we need the B to be high and we need the A to be low. So which hormone at day 21 is high, and which hormone, and that same hormone needs to be low at day 7? Progesterone. Let us see. You were right. Progesterone, absolutely. So we know that progesterone is high here because we have the corpus luteum that's secreting the progesterone. And right here, we talked about this earlier too, but progesterone is pretty low here. So something that is high here, low here, would have a high B:A ratio. All right. The graph shows the plasma hormone levels of LH, FSH, estrogens, and progesterone during a 28-day cycle of a healthy woman. If the egg of a woman is fertilized and develops into a zygote, what is the most likely time that it will implant into the endometrium? So out of A, B, C, D, E, where do you think in a normal healthy female does implantation occur? C would be ovulation, so D, absolutely. Again, you're absolutely right. So C is ovulation because of the LH surge, and it's like right here. Usually day 14 is where ovulation occurs. And so if ovulation were to occur here, these 7 days would be, it's traveling through the tubes, it's getting into the uterus. And so day 21 is most likely where implantation occurs. In a normal pregnancy, HCG prevents the involution of the corpus luteum that normally occurs at the end of the menstrual cycle. Which of the curves shown below approximates the level of this hormone during pregnancy? So we're talking about HCG, and which of these do you think is the most likely level of HCG throughout pregnancy? This is the HCG plasma level, the y-axis, and the x-axis is the weeks of pregnancy. Okay, A or B? Let us look at the answer. So the answer is A. Why is the answer A and not B? Although B is, I would say it's a sound answer, but why is it not B and why is it A? So we're talking about HCG levels, right? HCG in the beginning rise. We talked about this earlier as well, but HCG is the first hormone that is produced by the syncytiotrophoblasts. We know that HCG is responsible for preventing luteolysis. It prevents the degeneration of the corpus luteum so that it can keep secreting progesterone so that the endometrial lining stays intact for implantation to occur, right? So it's high. It should initially go really, really high because HCG increases to make sure that the corpus luteum is intact. However, what ends up happening afterwards, the amount of progesterone released by a measly corpus luteum is not enough to sustain the entire pregnancy, right? As the baby grows older, grows up and grows bigger and bigger in the womb, in the uterus, it's not going to be enough. The amount of progesterone secreted by the corpus luteum is not enough to sustain pregnancy. So what happens instead is that the placenta takes over after some time. Once the placenta is more mature, once it's a little bit bigger in size, it takes over, and it starts to secrete the hormone as well. So the HCG level would be really high here, but now the placenta itself has taken over to secreting progesterone, so we don't necessarily need HCG anymore. Okay. The normal pattern of progesterone secretion during the menstrual cycle is exhibited by which of the following curves? I know I've added so many graphs here, but one of your colleagues asked for a lot of graphs because I think apparently Dr. AJR was like, you guys are really bad at graphs. So every graph I saw, I was like, let me just add that. Yeah, you're right, D. So this is they just want to know the level of progesterone, and we know that progesterone is really low in the beginning, and we know that it, when the corpus luteum forms, we know that it increases in the second half of the cycle, which is also known as the luteal phase of the cycle. Perfect. Which of the following is the most likely cause of amenorrhea due to hypergonadotropic hypogonadism? This is a little bit of an advanced question, but I will go through it with you to make it easier for you to understand. But if you know the answer, you can try and guess. So we have somebody is guessing C. All right. So let's decipher the question stem itself. Hypergonadotropic hypogonadism. Hypergonadotropic refers to the hypothalamus, right? And the hypogonadism refers to the ovary, okay? Somebody said F, you are right, it is Turner syndrome. But let's talk about why it is Turner syndrome. Let's talk about all of these in order. So we have an eating disorder. So eating disorders and strenuous exercise can be grouped together. What happens with an eating disorder is that your body is really, really stressed out. When your body is super stressed out, it's very high on cortisol. And usually what happens with both strenuous exercise and an eating disorder is that the amount of GnRH actually goes down. It decreases. And so you wouldn't have hypergonadotropic hypogonadism, you would have hypogonadotropic because the hypothalamus isn't secreting enough. So that would be hypo. Hypo is low. Okay. Hyperprolactinemia is also one of the slides that I was showing earlier talks about how prolactin actually inhibits GnRH. And so again, in hyperprolactinemia, GnRH would be low, so it would be hypogonadotropic, not hyper. Kallmann syndrome is when you have failure to produce GnRH, right? So again, it's not hypergonadotropic, it's hypo. And pregnancy, we don't have a lot of FSH and LH in pregnancy. We do not want to stimulate more follicles. And so GnRH, again, in pregnancy is very low. Talking about Turner syndrome is when you have ovarian dysgenesis, right? So the problem is in the ovaries. So what happens is you have hypogonadism, which is when the ovary obviously isn't functioning properly. Your estrogen and your progesterone levels are super low. And so the hypothalamus looks at that and it's like, what, wait, there isn't enough estrogen, progesterone, I need to do something. So the hypothalamus is going to secrete more GnRH. The GnRH is going to cause an increase in the FSH and LH levels, but because the ovaries, and it's dysgenesis, the ovaries aren't produced properly, there isn't really much that we can do. And so hypergonadotropic, hypothalamus is overfunctioning, hypogonadism because the ovary isn't functioning well. Okay. A 24-year-old woman recorded her basal body temperature every morning before getting out of bed for 1 month, starting from the first day of her menstrual cycle. So they said day 1 is the first day of her menstrual cycle. The results are shown in the image. Which of the following can be concluded about her cycle that month? So, is it a normal female cycle, do you think? Is it a premature ovulation, short luteal phase, 1 ovulation, no ovulation, or 2 ovulations? I feel like there's a little bit, I wish it was on the options were on the same page as the graph. That would be easier. Shorter luteal phase, but still 14 days. So you're right, it is a shorter luteal phase. And why is that? Is because at ovulation, we know that there is a spike in the body temperature. So let's assume that most likely the ovulation occurred here, which would be day 21. Contrast that to the ovulation that occurs at day 14, which is the more common time period for ovulation. And so what happens is that the luteal phase, which occurs after ovulation, is much, much lower. There is an ovulation here, which is why D would be wrong. And there aren't 2 ovulation because there are no 2 peaks in the temperature. Premature ovulation also wouldn't make sense because the ovulation is later rather than earlier. And yeah, that's this isn't really normal. The normal would be ovulation occurring at day 14. Okay, we're almost close to the end. I think we have 3 or 4 more questions left. During her annual examination, a patient tells her gynecologist that she has noticed increased facial hair and acne. Ultrasound imaging of the ovaries reveal the presence of multiple cysts, and the diagnosis of PCOS is made. The patient's BMI is 32, indicating obesity. In this individual, the probable cause of her PCOS is C, peripheral conversion of estrone to androgen. So the thing is, yes, you're right that peripheral conversion of estrone to androgens does occur in PCOS. However, that is not the cause of PCOS. That is the cause of the symptoms. That is not why PCOS is occurring. The reason why PCOS occurs, yeah, you're right. It is B. So the reason why PCOS occurs is most probably, or the usual mechanism of action, is that you have a woman that is obese, right? Did somebody unmute themselves?
Wait, I think I'm on mute.
Would you like to say something?
I think how I understood it, and since her BMI is increased and hyperinsulinemia is one of the options. So what we learned in obesity is one of the key
Risk factor.
findings of type 2 diabetes. So at the same time, it can also be the primary reason for PCOS.
Yeah, you've explained it pretty much. Yeah, you're right. So most patients with PCOS are overweight or obese, and because of that, they would have insulin resistance and hyperinsulinemia. And insulin is basically what promotes the ovarian androgen production, and the androgens are why the symptoms are occurring exactly. They're not why you have PCOS, they're why the symptoms are occurring. And yeah, let's move on to the next question. After fertilization of the ovum, implantation occurs in the endometrium, and the developing placenta begins to produce a hormone necessary for embryonic viability. Which of the following is the action of this hormone? We've talked about this before in one of the earlier questions. Okay, I'll go over it. C. Somebody said C. You're absolutely right. So, right after fertilization, the hormone that is produced is HCG, as we talked about. And we know that HCG is responsible for stimulating the corpus luteum to produce more progesterone, so that we know that the lining of the uterus is intact enough to sustain implantation. So, yeah. Okay, is this our last question? Yes, it is. Okay, this is a long question, but I think if you're able to do this question, inshallah, like, you're good to go. This is a very, it is an easy question, but it's just very long, and it might seem a little bit daunting at first. So let's go over it together. For IVF, or in vitro fertilization, the female menstrual cycle is exogenously controlled. Exogenously controlled and stimulated utilizing several hormone treatments and assessments. A cycle begins by administering a receptor antagonist of hormone 1, which stops the hypothalamic pituitary gonadal axis for 1 week. Okay, so we're administering hormone 1, and this is going to stop HB. This is going to entirely stop the hypothalamic pituitary gonadal axis for the week. We talked about this in one of the other question stems. Which hormone do you guys think is responsible for completely halting the entire menstrual cycle? The one hormone that's responsible for controlling everything, you know, it's the mastermind of the entire cycle. Exactly, GnRH. So we know that hormone 1 is GnRH. Let's keep that in mind. During that week, there will be daily injections of hormone 2, which stimulate the development of large antral ovarian follicles. So we know that hormone 2 is, wait, let me just show you the question stem first. This is what the question looks like. They want us to identify which hormone is what. So hormone 1 is what, hormone 2 is what. And we can just go over it as we're reading the question, because I think that would be the easiest to decipher. So hormone 2 will stimulate development of ovarian follicles. What do you think is hormone 2? FSH, perfect. Hormone 3, okay, during the next week, ultrasound is used to monitor follicular growth, and hormone 3 is expected to increase. Which hormone do you think increases when the follicular growth is high? Estrogen, perfect. So now we know hormone 3 is estrogen. When several follicles are seen, hormone 4 is injected to induce oocyte maturation. What do you think hormone 4 is? LH, absolutely. Mature eggs are retrieved just before ovulation and mixed with or injected with sperm in vitro. The fertilized eggs are incubated for 3 days. During this time, the woman is injected daily with hormone 5. What hormone do you think is going to prepare the woman for implantation to occur? Progesterone, absolutely. Progesterone is going to make sure that the endometrial lining looks juicy enough for it to accept an implantation. After the embryos are transferred back to the uterus, hormone 6 is monitored to confirm potential pregnancy. What hormone are we testing in pregnancy? HCG, absolutely. So which of the following are hormones 1 to 6? The answer is D. Hormone 1 we said was GnRH, which was the one that they inhibited to halt the entire menstrual cycle. Hormone 2 was FSH, and we said this was used to stimulate the follicles. Hormone 3 was estrogen. This was the one that was rising when the follicles were developing. Now, hormone 4, I know we said was LH. Hormone 4 was injected to induce oocyte maturation. LH surge, yes, but sometimes HCG can also be administered exogenously to do the same thing, which is ovulation, to ovulate, help with ovulation. Hormone 5, we said, was progesterone to make the lining of the uterus more sustainable or more feasible for the implantation to occur. And then lastly, hormone 6, the hormone that we were using to monitor the pregnancy or to see whether or not the woman got pregnant, was HCG. that concludes our session on the practice questions for reproductive physiology. I would like to thank you guys for being with me here, and you're very welcome. And participating actively, that was very much appreciated. If you guys could just scan the QR code and let us know what you think of the session. Give us your feedback if there's anything that you liked, anything that you didn't like. I would be really, really appreciative if you could just fill out the form. You're very welcome. By the way, you guys can feel free to give us criticism as well, if it's constructive, of course. Because we would love to improve our sessions in the future. If there's anything that you would like to change, if there's anything in me that you would like to change, I'm open to that as well. So yeah, that's it. Thank you so much. And inshallah, you guys do great in your exam, inshallah.